CVA, or cerebral vascular accident, also known as stroke, has recently been referred to as brain attack. And the reason they gave it this label is because time is brain, and they want people to take it seriously. It occurs when there is a sudden loss of function from a disruption in the cerebral blood flow. It is the #1 most serious debilitating diagnosis in the United States to date. By the end of this presentation, your reading in Brunner and this lecture, you'll be able to identify risk factors for cerebral vascular disorders and measures for prevention. You will compare the types of cerebral vascular disorders, their causes, clinical manifestations, and medical management. You will explain nursing care related to a client in the acute stages of a stroke. Apply the nursing process as a framework for care of a client with an ischemic or hemorrhagic stroke, and discuss family and client education for safe care and preparation for home care of a client with a stroke. In review from your anatomy and physiology, it is important to know what areas of the brain control what in the body. The brain is divided into 3 major areas: the cerebrum, the brainstem, and the cerebellum. The cerebellum is what we're going to focus on, and it's composed of 2 hemispheres which are divided into lobes. The frontal lobe controls concentration, motor function, abstract thought, and memory. The parietal lobe analyzes sensory function, is essential to an individual's awareness of body position in space, size, and shape discrimination, and right-left orientation. The occipital lobe is where your visual interpretation and memory come from, and your temporal lobe contains your auditory and receptive areas. It plays a role in memory of sound and understanding of language and music. The circulation to the brain is divided into your posterior and your anterior circulation. And because it's a little complicated, I'm going to explain in more depth during lecture. But basically, your posterior brain circulation comes from your 2 vertebral arteries, and your anterior circulation comes from your common carotid artery, which branches off into your internal carotid artery. The circle of Willis, where they all come together, forms collateral circulation if one of the arteries that feeds the brain is occluded. So the functions of the 2 hemispheres. Your left hemisphere is very computer-like. It's responsible for verbal, linguistic, arithmetic, calculation, and analytic functions. And your right hemisphere is the creative side. It's responsible for geometric, spatial, visual, pattern, and musical functions. Right-handed individuals, along with some left-handed, have cerebral dominance on the left side of the brain. Risk factors for a stroke. Once you have a risk factor, being able to control those risk factors is a key element to decrease your risk of stroke. Primary prevention is the best approach. So what are the risk factors? They are hypertension, which is our #1 cause of stroke, carotid stenosis, atrial fibrillation, diabetes, dyslipidemia, excessive alcohol consumption, hypercoagulable states, migraines, obesity, sedentary lifestyle, obstructive sleep apnea, and smoking. And what's common about all of these risk factors is that they are modifiable. And we'll discuss how you can modify those risks during lecture. So what is the etiology of a stroke? It's caused from disruption of a cerebral blood supply caused by a thrombosis, which is formation or presence of a clot, a hemorrhage, when blood escapes through the wall of the blood vessel. This is what causes the hemorrhage. And an embolus, which is a clot, air bubble, piece of fatty deposit, foreign body, or bacteria that has been carried through the bloodstream to lodge in a vessel. The 2 types of stroke are ischemic, and this is from a disruption in the cerebral blood flow due to an obstruction in a blood vessel, and clots are the common cause of this, and hemorrhagic, which is primarily caused by intracranial and subarachnoid hemorrhage. It results in bleeding into the brain tissue, ventricles, or subarachnoid space, and the mortality rate for this is up to 50% for intracerebral hemorrhage. Ischemic stroke, as we had said before, is a lack of oxygen to the brain from a thrombus or an embolism. This disruption initiates a complex series of cellular metabolic events referred to as the ischemic cascade. Essentially, there is energy failures of the cells, which leads to acidosis and cell injury. The end result is that the area around the clot dies, causing damage to the brain. Vasodilation occurs to increase blood supply to the area and leads to edema, which causes further damage to the area. The penumbra is an area of low cerebral blood flow surrounding the infarction area. The cells in the penumbra area are hypoperfused. And a penumbra, if you look it up, is a shadow around something. And so when you look at scans, the penumbra looks like a shadow on the scans. And what's really important about the penumbra is that it is salvageable. So why is early identification so important? Because the drug that can save the penumbra is called TPA, and we'll discuss that further. But it can be administered within 3 to 4.5 hours following onset of symptoms. And like I said, it can save the penumbra area and decrease damage to the brain. A transient ischemic attack, or TIA, is temporary ischemia to a region of the brain. It presents as sudden loss of motor, visual, or sensory function. The symptoms last less than 1 hour, and it is a possible warning sign of impending stroke. In fact, 10% of clients will have a major stroke within 1 year following a TIA. And within 48 hours of a TIA, the risk of stroke increases significantly. So these patients are really high risk for stroke. And so what can we do for them? We can do a CEA, or carotid endarterectomy. And these are for patients who have carotid artery stenosis. A carotid endarterectomy is removal of an atherosclerotic plaque or thrombus from the carotid artery, and you can see that being done on the pictures on the left. Post-operatively, nursing responsibilities are first a focused neurological assessment. They are done frequently along with their vital signs. We have to really be alert for the risk of hypertension, and we have to assess the neck for edema and an incisional hematoma. And we'll go into a little further depth with those during lecture. Possible warning signs or the presentation of a stroke can be altered speech and vision, difficulty speaking or comprehending, altered gait, which can present as poor balance, dizziness, coordination, or weakness, weakness of the face, arm, leg, which will be unilateral, altered sensation. Deficit is on one side of the body. It can be the face, arm, and or leg, or the whole side. There can be a change in mental status, such as confusion or personality changes. They can present with a sudden headache. It's imperative to look at risk factors, previous TIAs and strokes. Warning signs can be related to other diagnoses. As you can see, all of these warning signs could be something else. And I want you to think about why it's important to get a thorough history on these patients. So years ago, we really didn't have any really good treatments for stroke as we do today. So public education is imperative to prevent the long-term and devastating effects of a stroke. Because if you get the client to the hospital quickly, they may be treated and we may save them from having the devastating effects. So we're going to teach the client and their family the acronym BFAST. Does the individual have a loss of balance, dizziness, or headache? That's our B. Our E, is there a change in or sudden loss of vision in one or both eyes? F, have the individual smile. Is it symmetrical or does the face look uneven? A is we're going to ask the individual to raise both arms. Can they hold them up or move it at all? And S, are they having difficulty speaking or understanding speech? And T is for time. And I said before, time is brain, and that is so true. So if any of the answers are yes, we instruct both the client and their families to call 911. Tissue plasminogen activator, best known as TPA, is a genetically engineered form of the thrombolytic substance that is made naturally by our bodies. It is the only medication that we do give for strokes at this time, and it has specific criteria along with a very specific and tight timeline. The goal is for the client to receive the IV bolus and drip initiation within 45 minutes of arrival to the ED. And I want you to think about that. That's a really tight timeline if any of you do work in an ED. TPA is administered in the ED or ICU only due to the need for close monitoring. We place 2 peripheral IVs. One is for the TPA because it has to go through a dedicated line, and the other one is in case we need to give the client anything else. The total dose is weight-based with a maximum dose of 90 milligrams. 10% of the dose is given IV push over 1 minute by a provider or advanced practitioner. The rest of the dose is given via an IV pump over 1 hour. Vital signs and neurochecks are performed every 15 minutes during infusion, and later we'll talk about vital signs and neurochecks after the infusion. Close monitoring for bleeding both internally and externally is done. And we do not give TPA for minor or rapidly resolving strokes due to the risk outweigh the benefits. So if a client goes to bed at night and wakes up with loss of vision in one eye, would they be a candidate for TPA, and why? So I want you to think about that when we meet for lecture. TPA has very strict criteria, and actually that criteria has changed over the last several years. It used to be that it can only be given within 3 hours from symptom onset. However, they have extended that window up to 4.5 hours today. In order to give it between the 3-hour mark and the 4.5-hour mark, it does require written consent for that extended 1.5 hours due to increased risk for cerebral edema and hemorrhage. And you have to remember that necrotic tissue develops within 3 hours of stroke onset. The client must be 18 years or older. We have to have good blood pressure control. The systolic blood pressure must be less than or equal to 185, and a diastolic blood pressure has to be less than or equal to 110. The client cannot be currently taking warfarin, and they cannot have taken low molecular weight heparin within 24 hours. The INR must be less than or equal to 1.7. The platelet count has to be greater than 100,000. And we do not administer TPA if the client had recent surgery, previous intracranial hemorrhage, subarachnoid hemorrhage, urinary or GI bleeding within 21 days, or a GI malignancy. And you can see the full criteria chart in Brunner. Endovascular therapy is one of our newer modalities of treatment. It is done in a hospital that is a certified stroke center with the capabilities of endovascular therapy. The criteria for endovascular therapy, and it's also known as neurointervention or clot retrieval. The criteria is the client must be 18 years or older. The client must have an NIH stroke scale of greater than or equal to 6, and we'll go over the NIH stroke scale in a little bit. They cannot have deficits prior to this new onset of stroke. They should have received TPA within 4.5 hours of the stroke onset. It must be a large vessel occlusion, such as the middle cerebral artery or the internal carotid artery, and it's also done for large vessels in the posterior circulation. And during lecture, I'll tell you about a real-life example of that I have seen. The groin puncture they want within 6 hours. That is preferred. However, today opens the window of treatment up to 24 hours. Nursing care post-endovascular therapy is the same as TPA for the neurochecks. So remember before I said, every 15 minutes during the therapy? Well, these clients, when they come back to you, then you start what you would be doing post your TPA. And that is your neurochecks and vital signs are done initially every 15 minutes for 2 hours, and then every 30 minutes times 6, and Q1 hour times 16 hours. And in most centers, you would do an NIH stroke scale every 2 hours for 24 hours. With addition to these checks, you have to do vascular checks for 6 hours post-procedure. And in this slide, I just give you a small example of a checklist that I actually developed in the center where I worked. And it's just a good checklist for us to stay up with what has to be done and when. Any changes in neurostatus requires a STAT CT scan due to risk of hemorrhage, and these clients are at risk. Assessing the CVA client includes diagnostic tests, and those would be CT scan, non-contrast, and that has to be initiated within 20 minutes of presentation to the ED. Strokes generally do not show up on CAT scan until 24 hours post-injury, so what we're really looking for is a negative CT scan to proceed. They have to have a set of full blood work along with an ECG. If less than 3 hours from onset of symptoms, the provider determines a diagnosis of CVA. The CT has been negative for a bleed. TPA will be administered with possible endovascular intervention. An MRI is not done initially because it takes too long, and we don't want to miss that window of opportunity for the TPA. So it is generally done 24 hours after intervention. We need to do focused neurological assessments. That includes level of consciousness, facial symmetry, perla, speech, vision, motor strength, and sensation of all 4 extremities. We have to assess for aphasia, and that's the inability to speak or comprehend language. Hemiplegia, which is a paralysis on one side of the body. Hemiparesis, which is a weakness on one side of the body. Ataxia, which is an impaired balance. And change in level of consciousness and confusion is a very serious sign, and we usually see that with serious bleeds or very large vessel strokes. Vital signs, generally a client presenting with signs of a stroke is hypertensive. The NIH Stroke Scale, or the National Institute of Health Stroke Scale, is an objective scoring system. It is a 15-item neurological examination stroke scale that evaluates level of consciousness, language, neglect, visual field loss, extraocular movement, motor strength, ataxia, which is impaired balance, dysarthria, which is difficulty speaking, and sensory loss. The total score ranges from 0, which is normal, to 42, which is a severe stroke. Certification in the administration of the stroke scale is highly recommended and should be recertified annually. So you just have to be familiar with what an NIH stroke scale is. You don't have to know all the different areas. I don't want you memorizing them. And what a normal and abnormal NIH stroke scale is. Further assessment of the client includes looking at their paralysis. If they have dysphagia, do they have aphasia, agnosia, or apraxia? Paralysis is broken down into 2 types, spastic and flaccid. Spastic paralysis is when the voluntary muscle control is lost and the nervous system tries to compensate. So the strong flexor muscles exert control over the extensors. The elbow, wrist, knee tend to flex, as well as internal rotation of the shoulder and external rotation of the hip joint. This results in cramping and spasms of the muscles, which can lead to contractures. In flaccid paralysis, you have complete loss of voluntary muscle movement with resultant muscle atrophy. Dysphagia is difficulty swallowing. Aphasia is loss of ability to comprehend language or speak it. And there are 3 types of aphasia. We have receptive, when the client cannot understand written and or spoken word but can speak it. In expressive aphasia, they have difficulty speaking but can understand what is said to them. And global is a combination of both receptive and expressive aphasia. Agnosia is the inability to recognize objects through sight, touch, or the auditory senses. And apraxia is the inability to carry out learned sequential movements on command, even when the individual has the desire or ability to do so. Right and left hemispheric CVAs. This diagram shows when there is a right hemispheric stroke, the left side is affected. And when there is a left hemispheric stroke, the right side is affected. So in right hemispheric stroke, the left side can have paralysis or weakness. The left visual field is affected. There can be a deficit there. Spatial perceptual deficits occur. The patient has distractibility. They have impulsive behavior and poor judgment. And they have a lack of deficit awareness, meaning that they don't realize that they have a deficit. In left hemispheric stroke, the right side can be paralyzed or weak. The right visual field can have a deficit. They have speech deficits, altered intellectual ability, and they have slow, cautious behavior. In hemorrhagic stroke, the prognosis is usually very poor. Hemorrhagic strokes account for about 13% of all strokes. For intracerebral hemorrhage, they account for about 10% of strokes, but account for 80% of bleeds. They are caused from spontaneous rupture of small blood vessels. The chief cause is uncontrolled hypertension and cerebral atherosclerosis. They are associated with AVMs, trauma, neoplasms, and certain drugs, anticoagulants, cocaine, and amphetamines. For subarachnoid hemorrhage, the bleeding is into the subarachnoid space from the rupture of a cerebral aneurysm. And an aneurysm is an outpocketing from a weakness in the vessel wall. From an AVM, which is usually congenital, and trauma such as a fall or hypertension. When caused by a ruptured aneurysm, there is significant morbidity and mortality. Most of these patients do not survive when it is sudden. Cerebral vasospasm is a serious complication of subarachnoid hemorrhage and occurs usually 7 to 8 days after the hemorrhage, but can occur up to 2 weeks following the hemorrhage. Nipotamine, which is a calcium channel blocker, is the drug of choice for prevention of these vasospasms. The symptoms of a hemorrhagic stroke can be similar to an ischemic stroke. The differences are early and profound changes in level of consciousness, vomiting, and seizures. The conscious client will complain of a severe headache, and the goal is to maintain cerebral perfusion. In the following slides, we're going to discuss nursing diagnoses and interventions for the client who has had a stroke. For altered cerebral tissue perfusion, nursing interventions are, and although I list ongoing neuroassessment here, it's not an intervention, as you know, but it is important as a reminder that we have to monitor these patients very closely. Platelet-inhibiting drugs such as aspirin and clopidogrel are prescribed for strokes related to thrombus or emboli. Anticoagulants such as warfarin, IV heparin, or low molecular weight heparins are used for embolic strokes related to atrial fibrillation. Statins will be prescribed and is one of the current stroke guidelines. So these patients, when they leave the hospital, have to be on a statin, or it has to be explained why they can't be on a statin. We assess and manage increasing intracranial pressure. And increasing intracranial pressure is obviously extremely dangerous and life-threatening. Increasing intracranial pressure is related to the edema following a large ischemic stroke or hemorrhage. These clients are monitored in the ICU. We elevate the head of the bed at least 30 degrees to help drainage. We avoid neck flexion, which increases intracranial pressure. We avoid hip flexion, which will increase intrathoracic pressure, making intracranial pressure difficult to control. Cluster care, although we try to cluster care for most clients, these clients we do not want to cluster care. It's contraindicated because too much activity at one time can increase intracranial pressure. These clients usually have severe deficits. They may be given osmotic diuretics such as mannitol and steroids such as Decatron. They may require a hemicraniectomy with continuous intracranial pressure monitoring. For impaired mobility related to hemiplegia, interventions include referral to physical and occupational therapy as soon as possible, and it's usually done within 24 hours of the stroke. For physical therapy, they're taught balance when sitting. They will start them out of bed and ambulating as soon as possible if they're capable. And these clients may start with a walker. They might progress to a cane. They may have a splint in their shoe of the affected foot if needed. It all depends on how bad their weakness is or how severe. When the clients are in bed, we turn and position them every 2 hours. If the client can tolerate the prone position for 15 to 30 minutes per day with pelvic and lower leg support, and that's one of the pictures on this slide, it will help not only the client's gait, but their hip joints and drainage of secretions. Passive and active range of motion are done at least 4 to 5 times per day. We want to maintain good body alignment by using known positions to prevent contractures. As stated before, with hemiplegia and hemiparalysis, the strong flexor muscles exert control, causing the arms to adduct and rotate internally. The elbow and wrist flex, and the legs rotate externally at the hip and flex at the knee. Pillows are used to separate the arm from the trunk to prevent adduction. A trochanter roll is used to prevent hip rotation. And splints are used to prevent contractures of the arms, wrist, hand, and foot. Splints can be used at night or on a usually 2-hour on, 2-hour off during the day, but it's the physical therapist that sets the schedule for splinting. Hand rolls used to be used, but they are not used if the upper extremity is spastic because it stimulates the grasp reflex and can cause a contracture. Shoulder pain. Shoulder pain occurs in about 80% of clients with stroke. So in order to alleviate or prevent shoulder pain, we never lift by the affected shoulder or arm. We support the arm and shoulder with a sling while up and a pillow in bed. We prevent shoulder subluxation and shoulder hand syndrome. We protect affected shoulder by bringing paralyzed arm and shoulder forward slowly by grasping the affected hand with the unaffected hand, and I can demonstrate that during class. And these clients may require analgesic and corticosteroids. Disturbed sensory perception related to homonymous hemianopsia. Hemianopsia is blindness in the same side of both eyes and is common in right hemispheric strokes. Our interventions are that we stand on the client's side where the vision is intact. We encourage the client to turn their head to the affected side for safety so that they can see what they're doing. We encourage the client to turn their head to scan the complete range of vision. And for meals, the client can only see food on one side of the tray. So we want to make sure we instruct our UAPs to set up trays so that the client can visualize everything that is on the tray. Dysphagia or impaired swallowing. Our interventions or management are a speech and swallow consult. We do a bedside swallow evaluation, and it's usually first performed in the ED using a validated and reliable tool. An example would be the Massey bedside swallow, and we'll review the steps to that in lecture. These clients may need thick and liquid diet or pureed diet. They need to be sat upright at 90 degrees for meals, preferably in the chair. We want to have them tilt their head forward when swallowing to prevent aspiration. We want to make sure that food is placed in the unaffected side of the mouth. And these clients may require NG tubes if they cannot swallow, if they are aspirating. And before being discharged, they would probably have a G or PEG tube placed. Good mouth care is essential. A lot of these clients, they don't even realize that they're storing food in the affected side of their mouth, and it can sit there and of course, cause infections and tooth decay, so it's really important to do good mouth care. For impaired thought processes in the stroke client, nursing interventions include frequent reorientation to time, place, person, events, what's going on around them. We support cognitive and perceptual retraining by implementing a care plan developed by the healthcare team. For right hemispheric CVAs, we protect from impulsive behavior because they tend to be impulsive. And for left hemisphere CVAs, we want to practice patience with slow behavior. So in this slide, I put this picture with the back of this t-shirt, aphasia, loss of language, not intellect. And I really love that because so many times because a client can't speak or understand us, we think that their intellect is impaired, and it may not be impaired. So really important for our nursing interventions. First, we want to determine the type of aphasia. We want to face the client and speak clearly. Don't yell, they aren't deaf, or at least most of them aren't deaf. If they have homonymous hemianopsia, it's very important to stand on the side that the client can see you, and we stated that previously. Don't finish the client's sentences. I know it can be difficult and you need a lot of patience for them to finish their sentences, but it's important to allow them to finish them. Supplement words with pictures, gestures, and objects if it's a left hemisphere stroke because they have limited language skills. And minimize distractions, especially with clients with right hemispheric stroke, because they are impulsive and move quickly, and distraction may aggravate this and limit a caretaker's ability to focus on the client. For ineffective airway clearance and the risk for aspiration, nursing interventions include providing pulmonary care. If ineffective airway clearance is severe, suction will be required. We want to give them thickened liquids. We want to give them a dysphagia diet. Sitting at a 90-degree angle or sitting in a chair for meals. And you can see these are repetitive of previous interventions, but still very important. And neck flexion when swallowing will help prevent aspiration. Unilateral neglect occurs in right hemisphere strokes. When it occurs, the patient is unaware of one side of the body. Clients must be supervised. Do not rely on them. They don't realize that they are neglecting one side. We want to assess limb position. We want to prevent hanging limbs. For example, when they're sitting in a chair and their arm is just hanging over the side, they don't even realize it. We want to break down tasks into small steps due to the poor memory that they have. They need verbal cues, not pictures, due to the loss of perceptual skills to be able to recognize something. And do not overestimate their abilities. They do not have speech deficits, so they sound like they know what they are doing, but they don't realize what is going on one side of their body. Interrupted family processes. So a CVA can cause significant challenges for the family and caregiver. We want to educate the family caregiver that stroke is considered a family disease because of its effects on all members of the family. Clients may have aphasia, behavioral changes, sensory and mobility deficits. Length of rehabilitation may take months. Nutrition strategies they need to prevent aspiration. We want to provide anticipatory guidance for caregiver role strain. And remember, depression in both the client and caregiver is prominent following a stroke. We need to make home care agencies, stroke support groups, and respite care available to family members. We have to remember that stroke is the #1 disabling disease, and it can have a large financial impact with loss of income. And homes may need handicap adjustments such as rails, ramps, sink heights, etc. And that can be another financial impact for these families. Clients may go home with assistive devices. And in the next slide, I'll show you some of those assistive devices. In this slide, these are some of the assistive devices you may see. We have a 4-pronged cane, a walker, we have splints, we have specialty shoes, and even life alerts. So it's important to know what these assistive devices are and how they are placed on the patient. And this is the end of the voiceover. In class, we'll follow this with some case studies.